A neoplasm is a lesion resulting from abnormal growth of a tissue which is partly or completely autonomous of normal growth controls and persists after the initiating stimulus has been removed. Classification of tumors. Behavioral classification, benign or malignant. Histogenetic classification, cell of origin. Behavioral classification. The behavioral classification divides tumors into benign, malignant. The pathological criteria for classifying a tumor as benign or malignant are shown in box 18.1. Histogenetic classification, classification by cell of origin. Histologically determined. Degree of histological resemblance allows tumor to be graded. Grading correlates with clinical behavior. Major categories of tumor origin: from epithelial cells, from connective tissue cells, mesenchymal, from lymphoid and hemopoietic tissue. Differentiation: the degree to which the tumor histologically resembles its cell or tissue of origin. Degree of differentiation determines the tumor grade. Well-differentiated resembles parent tissue more than poorly differentiated tumors. Poorly differentiated may be so poorly differentiated that they lack easily recognizable histogenetic features. They are more aggressive than well-differentiated tumors. Moderately differentiated, intermediate between well and poorly differentiated tumors. Tumors defying histogenetic classification are called anaplastic. Nomenclature of tumors. All have the suffix -oma. Benign epithelial tumors are either papillomas or adenomas. Benign connective tissue tumors have a prefix denoting the cell of origin, e.g. lipoma, fat, osteoma, bone. A carcinoma is a malignant epithelial neoplasm. A sarcoma is a malignant connective tissue neoplasm. Epithelial tumors. Benign tumors. Papilloma, benign tumor of non-glandular or non-secretory epithelium, e.g. transitional or stratified squamous epithelium. Adenoma, benign tumor of glandular or secretory epithelium, e.g. colonic adenoma. Malignant tumors. Carcinoma, malignant tumor of epithelium, e.g. squamous cell carcinoma. Adenocarcinoma, malignant tumor of glandular epithelium, e.g. adenocarcinoma of the stomach. Carcinoma in situ, a lesion with all the cytological features of cancer but no evidence of invasion through the epithelial basement membrane, e.g. ductal carcinoma in situ, CIS, of the breast. Connective tissue tumors. Tumors of connective tissue are named according to the cell of origin and behavioral classification. Teratomas. A teratoma is a germ cell neoplasm representing all three germ cell layers, i.e. ectoderm, mesoderm, and endoderm. Ovarian teratomas tend to be benign and cystic. Testicular teratomas tend to be malignant and solid. Embryonal tumors, blastomas. These bear a histological resemblance to the embryonic form of the organ from which they arise. Nephroblastoma, Wilms tumor, kidney. Neuroblastoma, adrenal medulla, autonomic ganglia. Retinoblastoma, eye, inherited predisposition. Hepatoblastoma, liver. Apudomas and carcinoid tumors. APUD, amine content and or precursor uptake and decarboxylation. Describes cells of diffuse, neuroendocrine system. Examples of apudomas and their clinical manifestations are insulinoma, episodes of hypoglycemia, gastrinoma, extensive peptic ulceration, Zollinger-Ellison syndrome, pheochromocytoma, paroxysmal hypertension. Carcinoid, if metastases are present, flushing, palpitations, and pulmonary valve stenosis. Mixed neoplasm, a neoplasm showing more than one neoplastic component, usually both epithelial and mesenchymal, e.g. pleomorphic adenoma of the parotid, glandular tissue in a cartilaginous or mucinous matrix, fibroadenoma of the breast. Carcinosarcomas are most common in the female genital tract. Hamartomas. A hamartoma is a tumor-like lesion which lacks autonomy but in which the elements are fully differentiated and are normally found in the tissue of origin. They usually contain two or more mature cell types native to the organ of origin, but the constituent parts are abnormally organized, e.g. pigmented navy. Pulmonary hamartomas, which consist of a mixture of cartilage and bronchial epithelium. Poorly named tumors, misnomas. Lymphoma, malignant, therefore lymphosarcoma. Hepatoma, malignant, therefore hepatocellular carcinoma. Melanoma, malignant, therefore melanocarcinoma. Tumor growth patterns. Sessile, polypoid and papillary tumors are likely to be benign, but not always. Fungating, ulcerating, annular and infiltrating tumors are likely to be malignant. Ulcerated tumors can often be distinguished from benign ulcers. The latter have sloping edges while the former have rolled, everted edges, e.g. squamous cell carcinoma. Encapsulated tumors tend to be benign. Beware the false capsule of compressed connective tissue, e.g. pleomorphic adenoma of the parotid. Shelling out this tumor would leave residual tumor. Histological pattern. Malignant features include loss of differentiation, disordered growth pattern, variability in cell size, variability in nuclear size, high nuclear cytoplasmic ratio, increased mitotic activity, abnormal nucleoli may be multiple, abnormal chromatin pattern. Carcinogenesis. This is the process by which normal cells are converted into cells capable of forming neoplasms. A carcinogen is an agent known or suspected to participate in the causation of tumors. Such agents are said to be carcinogenic, cancer-causing, or oncogenic, tumor-causing. Strictly speaking, carcinogenesis applies to the causation of malignant tumors, whereas oncogenesis includes all tumors, benign and malignant. The main classes of carcinogen are chemicals, radiation, viruses, hormones, bacteria, fungi, parasites, other agents. Chemicals. Polycyclic aromatic hydrocarbons. Scrotal cancer in chimney sweeps due to exposure to polycyclic aromatic hydrocarbons in soot of historical interest. 3,4-benzpyrene in tobacco smoke. Carcinogenic. On direct contact, e.g. smoking, but absorbed into bloodstream, which may explain why smokers have higher incidence of cancer at other sites, e.g. kidney, bladder. Carcinogenic components of tar, which can cause skin cancers by direct contact. Aromatic amines. Beta-naphthylamine, high incidence of bladder cancer in dye and rubber industry. Nitrosamines, gut cancers in animals. Azo dyes, bladder and liver cancers in animals. Alkylating agents, e.g. cyclophosphamide, small risk of leukemia in humans. Radiation. UV light is a major cause of skin cancer. Exposure to ionizing radiation is associated with increased risk of cancer at many sites, e.g. carcinoma of the thyroid after childhood irradiation of the neck, increased incidence of leukemia and carcinoma of breast, lung and thyroid after nuclear explosions at Hiroshima and Nagasaki during the Second World War, cancer of thyroid after Chernobyl disaster, which released radioactive iodine, leukemia and liver neoplasms developing years after exposure to thorium-containing contrast, medium, thorotrast, angiosarcoma developing at the sites of previous radiotherapy treatment for breast cancer, viruses, HPV, common wart, cervical carcinoma, strong association with HPV, type 16 and 18. EBV, Burkitt's lymphoma, nasopharyngeal carcinoma, B-cell lymphoma in immunosuppressed patients. Hepatitis B virus, hepatocellular carcinoma, HIV, Kaposi's sarcoma. HTLV1, T-cell lymphoma/leukemia. Hormones. Experimentally, estrogens can be shown to promote formation of breast and endometrial carcinoma. Increased incidence of endometrial carcinoma in postmenopausal women treated with estrogen-containing compounds. Androgenic and anabolic steroids are known to induce hepatocellular tumors in humans. Bacteria, fungi, parasites. Helicobacter pylori implicated in the pathogenesis of gastric lymphoma. Aflatoxins, B1, produced by Aspergillus flavus have been linked to high incidence of hepatocellular carcinoma in certain areas of Africa. Schistosoma is strongly implicated in the high incidence of bladder cancer where infection, schistosomiasis, is rife, e.g. Egypt. Clonorchis sinensis, liver fluke dwells in bile ducts, where it may cause cholangiocarcinoma. Other agents: asbestos, mesothelioma, strong association, carcinoma of the bronchus. Metals. Nickel exposure is associated with nasal and bronchial carcinoma. Betel nut. Chewing betel nut is associated with increased risk of neoplasms of oral cavity. Host factors and carcinogenesis. Race. Diet. Inherited predisposition. Age. Gender. Race. Precise role unknown due to coincidence with diet, habit and location. Incidence of oral cancer high in India and Southeast Asia, but probably related to chewing betel nut. High incidence of hepatocellular carcinoma in Africa and Southeast Asia, but is probably related to exposure to dietary carcinogens and viral hepatitis. Immigrant groups tend eventually to assume the disease profile of their adopted country. Diet, aflatoxins and hepatocellular carcinoma. Diet low in fiber in colorectal cancer. High dietary fat in breast cancer. Inherited predisposition. Some diseases appear to run in families, cancer, families. A woman whose mother and one sister have breast cancer stands a 50% probability of developing the disease. Examples of familial cancer are shown in Table 18.2. Age. The incidence of cancer increases with age. This reflects the cumulative effects of exposure to carcinogens with age. Effects of immune defenses may be lost with old age. Familial neoplasms occur at a younger age than sporadic neoplasms. Individual neoplasms have their own specific age distribution, e.g. fibroadenoma of the breast, 18 to 35 years, carcinoma of the breast, more common after the menopause, neuroblastoma, childhood. Gender. Carcinoma of the breast is 200 times more common in women than in men. The commonest tumors in men and women differ. Premalignant disease. A premalignant lesion is a discrete identifiable lesion associated with an increased risk of progression to a malignant neoplasm. Examples include benign neoplasms that can become malignant, e.g. colorectal adenoma carcinoma sequence, figure 18.1, Dysplasia/in situ malignancy. Metaplasia, dysplasia sequence, Table 18.3. A premalignant condition is a non-neoplastic condition, which is associated with an increased risk of developing malignant tumors. Examples of premalignant lesions and conditions are shown in box 18.3. Carcinogenic process. Multi-step theory. Latency. The causal event is usually followed by a variable but usually lengthy delayed period. This is because more than one effect is required for cancer to develop multi-step. It takes time for the mutated cell to produce a clone of a significant number of cells to produce signs and symptoms. Initiation, exposure of cells/tissue to carcinogen and induction of lesion in cell's genome bestowing neoplastic potential, irreversible. Promotion, the event stimulating clonal proliferation of the initiated transformed cell. A promoter is a substance that will cause cancer in an initiated cell, but not a normal cell, e.g. croton oil in experimental skin cancers initiated by methylcholanthrin. Persistence, initiators and promoters no longer required. The tumor becomes autonomous with vascular ingrowth, increased growth rate, invasiveness and metastasis. Genetics of cancer. An increased predisposition to development of malignant neoplasm may be inherited as part of a clinical syndrome with other diagnostic features in addition to the increased risk of malignancy, e.g. acute leukemia in Downs syndrome, an increased likelihood of neoplasia developing as the only manifestation, e.g. familial retinoblastoma syndrome. Inherited syndromes associated with an increased risk of malignancy are syndromes with a major chromosomal abnormality, e.g. Down syndrome and acute leukemia, syndromes determined by single gene defects, e.g. familial polyposis coli and colorectal cancer. Evidence for genetic alterations causing cancer. Translocations, part of one chromosome becomes attached to another, e.g. Philadelphia chromosome, and chronic myeloid leukemia, CML, Burkitt's lymphoma. Extra chromosomes, usually trisomies, i.e. 3 copies of a chromosome rather than 2, e.g. Trisomy 21, Down syndrome, acute leukemia. Familial aggregations, e.g. retinoblastoma. Increased risk of malignancy associated with incapacity to repair damaged DNA, e.g. xeroderma, pigmentosum and skin cancers. Association between chemical mutagens and their carcinogenic effects, see above. Evidence that mutation or unregulated expression of certain genes converts normal cells to malignant cells. Genetic mechanisms. In carcinogenesis, two important genetic mechanisms leading to neoplasia are abnormal or excessive expression of dominant stimulatory genes, oncogenes, loss or inactivation of recessive inhibitory genes, tumor suppressor genes. Abnormal expression of oncogenes drives normal cells towards a neoplastic state. Loss of tumor suppressor gene function allows neoplastic transformation as a result of oncogene expression. Oncogenes, genes whose presence in certain forms and/or activity can stimulate the development of cancer. Oncogenes contribute to the development of cancer by instructing cells to make proteins that stimulate excessive growth and cell division. Oncogenes are related to normal genes called proto-oncogenes. Proto-oncogenes are a family of normal genes that code for proteins involved in the normal growth control pathway of a cell. Growth factors, receptors, signaling enzymes, and transcription factors are encoded by proto-oncogenes. Oncogenes arise from mutations of proto-oncogenes. Oncogenes code for altered versions or excessive quantities of growth control proteins that disrupt the growth signaling pathway of the cell. The growth signaling pathway becomes hyperactive, and cells grow and divide more rapidly. A cancer cell may contain one or more oncogenes, such that one or more components of the pathway may be abnormal. Examples of oncogenes and their products are shown in Table 18.4. Tumor suppressor genes, normal genes whose absence can lead to the development of cancer. Tumor suppressor genes are categorized according to their mechanism of action, Table 18.5. Caretaker genes maintain the integrity of the genome by repairing DNA damage. Gatekeeper genes inhibit proliferation or promote the death of cells with damaged DNA. If a pair of tumor suppressor genes are lost from a cell or inactivated by mutation, cancer can result. Individuals who inherit an increased risk of developing cancer are often born with a defective copy on one tumor suppressor gene. Because genes come in pairs, an inherited defect in one copy will not cause cancer if the other normal copy is functional. If the second copy undergoes mutation, then cancer may occur because there is no longer a functional copy of the gene. Examples of tumor suppressor genes, RB gene and retinoblastoma. Individuals with an inherited predisposition to develop retinoblastoma are born with absence of one of normally paired RB1 suppressor genes. Only one further mutational loss of the remaining RB1 gene is required for retinoblastoma to develop. High risk of bilateral familial retinoblastoma. Individuals with paired RB1 genes have a low incidence of retinoblastoma because two mutational losses in the same cell or daughter cells would be required, hence, sporadic retinoblastoma is very rare. Risk of unilateral retinoblastoma. P53 tumor suppressor gene, situated on short arm of chromosome 17. Most frequently mutated of the class of genes. Normal functions are repair of damaged DNA before S phase of cycle, by arresting cell cycle in G phase until damage is repaired, apoptotic cell death if DNA damage is extensive. Inherited germline mutations of P53 occur in the rare Li-Fraumeni syndrome, giving an inherited predisposition to a wide range of tumors. Behavior of tumors. Invasion. Invasion is the sole most important criterion for malignancy. Metastases are a consequence of invasion. Invasion demands that tumors should be removed in continuity with a wide margin of apparently normal tissue. Factors influencing tumor invasion include abnormal or increased motility. Malignant cells are more mobile than their normal counterparts. Secretion of proteolytic enzymes. Matrix metalloproteinases are secreted by malignant cells. They digest surrounding connective tissue, e.g. interstitial collagenases degrade collagens, type 1, 2, and 3. Decreased cellular adhesion. Loss of surface adhesion molecules, e.g. cadherins, enable migration of individual cells. Clinical consequences of local invasion. Clinical consequences of local invasion depend upon the site of the tumor. Box 18.4 indicates some of the clinical consequences of local invasion of bronchial carcinoma. Metastasis. Metastasis is the process whereby malignant tumors spread from their site of origin, primary, to form other tumors, secondary, at distant sites. Metastasis is tumor spread in discontinuity as distinct from invasion, which is spread in continuity. Steps in the metastatic cascade. Detachment of tumor cells. Invasion of surrounding tissues to reach vessels. Intravasation into lumen of vessels, blood and lymphatics. evasion of host defense mechanisms, adherence to endothelium at remote location, extravasation from vessel lumen into surrounding tissue, survival and growth within the tissue, establishment of own blood supply, routes of metastasis, lymphatic, regional lymph nodes, hematogenous, via the bloodstream, transcoelomic, across peritoneal, pleural and pericardial cavities, seeding or implantation during surgery, lymphatic. Most carcinomas spread via lymphatics, may remain discrete in lymph nodes or invade outside nodes, involving adjacent nodes and connective tissue when they become matted together. Melanomas may permeate lymphatics and appear as black streaks in subcutaneous tissue. Lymphatic blockage causes lymphedema of tissues. In the breast, it is associated with peau d'orange. Hematogenous. Bone is a favored site for hematogenous spread from 5 carcinomas: lung, breast, thyroid, kidney, and prostate. Other favored sites are lung, liver, and brain. Sarcomas spread by the bloodstream and not lymphatics. Transcoelomic. Spread of carcinoma of stomach to ovaries, Krukenberg tumors. Spread of ovarian cancer to omentum and peritoneum, ascites. Spread of bronchial carcinoma to pleura, pleural, effusion. Seeding or implantation at surgery. Tumor grows in sites of surgical incision or investigation, e.g. FNA. Clinical effects of tumors. These may be local, systemic, paraneoplastic, metabolic. Others. Local, mass. Bleeding due to ulceration, hematemesis, hematuria. Pain. Obstruction, hollow tube, e.g. large bowel obstruction, with carcinoma. Irritation at tissue of origin, e.g. cough due to bronchial tumor. Pressure on adjacent structures, e.g. nerves, blood vessels, bile ducts, cancer of head of pancreas, and obstructive jaundice. Systemic. Effects of metastases. Enlarged lymph nodes may be discrete or hard, irregular and matted. Hepatomegaly. Primary tumor in stomach, colon, bronchus or breast. Jaundice. Nodes in porta hepatis with primary tumor in stomach, pancreas or colon. Ascites, ovarian or any gastrointestinal, GI, malignancy. Abdominal mass due to omental secondaries, often in association with ascites. Pathological fractures due to bony metastases, breast, bronchus, thyroid, prostate or kidney. Pleural effusion, bronchial carcinoma and breast cancer. Fits, confusion, personality change from cerebral metastases, e.g. breast, bronchus or malignant melanoma. Anemia, pancytopenia, bone marrow deposits. Paraneoplastic effects. These are effects that occur in the presence of a neoplasm which are not directly caused by the tumor itself or metastases. They can be divided as follows: humoral, mediated by a tumor-secreted product, immunological, usually autoimmune. Humoral, bronchial carcinoma and Cushing's syndrome due to inappropriate secretion of adrenocorticotropic hormone, ACTH. Bronchial carcinoma and inappropriate secretion of antidiuretic hormone, ADH, vasopressin. Hypercalcemia of malignancy caused by secretion of parathyroid hormone-related peptide. Carcinoid syndrome with liver metastases from a carcinoid tumor due to 5-hydroxytryptamine, 5-HT, serotonin. Immunological. Autoimmune disease may be triggered by malignancy. Dermatomyositis developing in later life may be due to an underlying malignancy. Membranous glomerulonephritis can be initiated by an underlying malignancy. Metabolic effects. These are usually hormonal and reflect appropriate secretion of hormones. Thyrotoxicosis from thyroid adenoma, Cushing's syndrome from adrenal cortical adenoma, hyperparathyroidism from parathyroid adenoma, insulin from an insulinoma. Others. Cachexia, all tumors, probably multifactorial. Pyrexia of unknown origin, pyelolymphoma, hypernephroma. Hypertrophic pulmonary osteoarthropathy associated with bronchial carcinoma. Thrombophlebitis migrans associated with visceral cancer, usually carcinoma of the head of the pancreas. Acanthosis nigricans associated with carcinoma of the pancreas. Tumor markers. Neoplastic cells often have quantitative and qualitative abnormalities of protein synthesis. They may either overproduce a normal product or they may produce a substance which is abnormal for their tissue of origin. Protein production by some tumors has been utilized clinically as tumor markers. Examples of tumor markers are shown in box 18.5. A tumor marker may be a substance which is secreted into the blood or other body fluid or expressed on the cell surface of malignant cells in larger quantities than in normal counterparts. Detection is by measuring the concentration of the marker in the body fluids, usually by immunoassay. Some markers may be detected in histological sections using immunohistochemistry. Tumor markers are rarely sufficiently specific to be of absolute diagnostic value. The main value of tumor markers is in following the course of a malignant disease and monitoring the response to treatment and hence prognosis. Tumor markers can also be used for tumor localization and antibody-directed therapy. Tumor dependency. Although the growth of tumors is autonomous, some retain a requirement for growth factors/endocrine support. Good examples of those requiring endocrine support are carcinomas of the breast, prostate, and thyroid. Breast. A large proportion of breast carcinomas express estrogen receptors. The degree of estrogen receptor expression correlates well with the response of the tumor to estrogen blockade, e.g. with the selective estrogen receptor modulating drug tamoxifen. Estrogen receptor positive tumors tend to be of a lower grade and have a better prognosis than estrogen receptor negative tumors. Prostate. Prostatic epithelium is dependent on androgenic stimulation. Castration results in apoptosis of prostate epithelial cells and partial involution of the gland. Many prostatic carcinomas retain the above characteristics, allowing their growth to be inhibited by androgen blockade. Androgen blockade can be achieved by orchidectomy. Estrogens, side effects unacceptable. Luteinizing hormone, LH, released from pituitary, stimulates androgen production by Leydig cells. LH production can be inhibited by luteinizing hormone-releasing hormone, LHRH, which after transient stimulation causes long-term depression of LH release. After a period of time, androgen sensitivity is lost and therefore the above treatments are not curative. Thyroid. Papillary and follicular carcinoma respond in the same way as normal thyroid epithelium to thyroid-stimulating hormone, TSH. TSH suppression with thyroxine, in conjunction with surgery and radioiodine therapy, is used to treat these neoplasms. Prognosis of tumors. This depends on type of tumor, stage, extent of spread, grade, degree of differentiation, surface receptors, e.g. estrogen receptors in breast cancer. gene expression, sensitivity to treatment modalities, age, nutritional status, immune status and human leukocyte antigen, HLA, type. Tumor staging. This represents the extent of spread. Staging can be assessed as follows: clinical assessment, imaging techniques, histopathological examination of resected specimen. Some types of staging rely on one of the above alone, e.g. Duke's classification, and some rely on a combination, TNM. Staging is designed to define prognosis. Duke's classification, a pathological classification drawn up by Cuthbert Dukes, pathologist, originally to stage rectal cancer, but now extrapolated to colorectal cancer. Dukes A, invasion into, but not through, the bowel wall. Dukes B, invasion through the bowel wall. Dukes C, involvement of regional lymph nodes. Dukes D was not in the original classification but was added later, indicates distant metastases. TNM classification. T, primary tumor. Number suffix indicates tumor, extent or size. N, lymph nodes. Number suffix indicates number of lymph nodes or groups of lymph nodes involved. M, metastases. Number suffix indicates presence or absence. Example, TNM classification for carcinoma of the breast. TIS, carcinoma in situ. T0, no primary located. T1, tumor less than 2 cm. T2, tumor 2 to 5 cm. T3, tumor greater than 5 cm. T4, extension to chest wall plus or minus skin. N0, no nodal involvement. N1, mobile ipsilateral axillary nodes. N2, fixed ipsilateral axillary nodes. N3, ipsilateral supraclavicular nodes. M0, no metastases. M1, distant metastases. MX, metastases suspected but not confirmed. Other staging. Malignant melanoma. Breslau's classification, the distance between the stratum granulosum and the deepest part of the melanoma. Directly related to survival. Less than 0.76 mm, very good prognosis. Greater than 4.0 mm, very poor prognosis and high risk of metastases. Clark's classification, defined according to anatomical boundaries, relates to anatomical area of penetration, e.g. level 1, confined to epidermis, to level 5, tumor cells present in the subcutaneous tissue. Breslau's classification is more widely used and has an influence on the surgical margins taken. These margins are a source of controversy and vary between countries, but current UK guidance states that if a lesion is less than or equal to 1 mm thick, then a 1 cm margin is taken, 1.01 to 4.0 mm, then a 2 cm margin is taken, and greater than 4 mm, then a 3 cm margin is taken. Screening. Population screening programs are aimed at reducing morbidity and mortality from a particular disease within an entire population. Screening should be directed at an asymptomatic population at risk. The principles underlying screening depend on the following. For screening to be cost-effective, the cancer must constitute a major health risk, i.e. high incidence, and high mortality rate. It must be a relatively common disease, e.g. breast cancer in the UK, gastric cancer in Japan. There must be an established and effective treatment for the disease. It must be demonstrated that early diagnosis and treatment do increase the cure rate. There must be a diagnostic test available that can be applied to a large number of people. The test must have a high level of sensitivity and specificity. The test should not cause harm to the individual being tested. The cost of screening large populations must be justified by the yields. Screening programs, breast, mammographic screening. Women aged 50 to 70 years old, currently being extended to women aged 47 to 73 years old in some areas of the UK as a trial extension of the program. Repeated 3 yearly. Cervix, exfoliative cytology. Identification of cervical intraepithelial neoplasia, CIN. Coordinated national screening program in the UK. Women aged 25 to 49 years old, screened every 3 years. Women aged 50 to 64 years old, screened every 5 years.